For those of you, you may need the closed captioning in about a month's time to understand my Australian accent. So I'll do my best to speak slowly and clearly, because clearly it's relevant to most of you who probably have hearing loss. But I'm very much used to speaking to people with hearing loss, so let's get into it. I always like to start with a few disclosures. I'm involved with a bunch of different companies, of which you'll hear about in here, but also importantly, we're a big family here at Stanford, and a lot of this material is being contributed by Dr. Gergel, who's an ex-fellow here, and also our chair, Dr. Jackler. This is a slide that I always like to start off with. So this was Helen Keller, who's one of the most famous deaf and blind people in the world. And when asked about what was worse, being blind or being deaf, she said being deaf, and this is why. Because blindness separates people from things, but deafness separates people from people. And the thing that I see amongst patients as you grow older is having hearing loss changes who you are as a person. You contract your social circles, you stop going out to dinner, you stop talking to your extended family, you start to hide from noisy situations, and before you know it, you're changing as a person. And that's, I think, the biggest reason why we should be treating hearing loss, is because we're trying to keep who you are as a person, which really is meaningful as we grow older. It's very common. 1 in 3 over the age of 65 is going to have hearing loss. It's the number 2 most common illness presentation in that population, and it leads to a huge amount of costs, $750 billion. And who notices it? Well, it's not just the individual. Often it's more the family members, particularly the spouse and work colleagues. But this is where it really costs money to the healthcare system, because when you can't hear, you often have sensory deprivation. You don't hear something coming alongside you, and it often leads to falls, which then lead to fractures in hospital. Fracturing your hip is a really big problem associated with falls, and we know that there's a very high mortality associated with fractured hips. This is something that scares everyone when I put it up. It scares me. It's certainly. We have been doing a lot of research in the cognitive effects of hearing loss. And it gets very scary when you talk to people and talk about untreated hearing loss being a big risk factor for dementia, in particular with Alzheimer's disease. This study was published in The Lancet a few years ago. And if we look at the journey to risk factors going along towards Alzheimer's, and of course there's some risk factors that you're born with. And towards the end, there's some risk factors like smoking, depression, isolation that can really impact you. But if you look at middle life, if you don't treat hearing loss in the middle of your life, there's a 9% increased risk of Alzheimer's disease. And that's very, very scary. And that's often the thing that when I talk to patients and they're thinking about, I'm really resistant to having hearing aids or hearing devices. That's when I start talking about, you're changing as a person. It's actually keeping you aware of your surroundings and reducing your risk towards dementia. And why is that? Kind of what I've already been saying about the sensory deprivation around you. And just think of how hard it is how much your brain goes into overdrive when you can't hear and you're trying to hear things, as well as trying to process a car coming this way, your spouse talking to you this way, and all of a sudden you get to cognitive overload. So cognitive overload is big here with hearing loss. So let's take a little step back and think about how we hear. So when you hear, the sound comes in through your ear. It travels through your ear canal, you can see on the left. It hits your eardrum, what I did my PhD in, and it vibrates these middle ear bones in the middle ear. That acoustic energy gets transmitted into the cochlear, which is the inner ear, kind of that snail-looking thing there in green that you can see on the picture there. That traveling wave of acoustic energy vibrates the basilar membrane, and it makes these hair cells depolarize. And those hair cells there you can see in purple. If you were to stretch the cochlear out into a long wave, each wave on that basilar membrane corresponds to a different frequency. So it's very frequency specific how that membrane vibrates. That then gets transmitted into nerve electricity and gets transmitted into the brain and interpreted as sound. So There's a whole bunch of different tests that we use to screen for hearing loss. But it's kind of funny, one of the more sensitive things is just simply asking a patient or their spouse, do you have trouble with your hearing? And that's actually been shown to be very sensitive as a very, very basic screening tool. By the time that most people see me in clinic, it's usually they should have seen me a little while ago. So by the time that you think that you're struggling, it's probably too late. We should have intervened a little bit earlier. And if we look at hearing loss as a prevalence through age, of course, as we get older, our hearing declines. But if you match that with hearing aid use there in red, you can see the disparity, growing hearing loss and not much in terms of growth in terms of hearing aid use. So why is that? Why, as a very basic intervention that's very widely available, why is that? Well, the biggest thing that I sort of see is two things. One is cost and affordability. It's a crime in this country and many countries, including where I was born, that hearing aids aren't easily accessible by insurance providers. And so it's very difficult as you're retiring and you have your costs mounting to find the cost for hearing aids. And one thing that we do to address this, I'll talk about in a bit. The other one is the resistance, the lack of the stigma associated with hearing loss. You don't want to admit that you're losing your hearing or that you're growing older. This was a really interesting article from the New York Times back in, I have to read the 1980, I think. 1983, there we go. About Ronald Reagan, and this quote from there really shows you what the stigma is like with hearing loss that we're all aware of. So among presidential advisors, Mr. Reagan's use of a hearing aid revived speculation on whether his age would be an issue if he seeks re-election next year. So they were questioning his ability to be president or to function just by the fact that he has a hearing aid, and that's crazy. The number of world leaders that we know that had hearing loss is large. And just to give you a bit of comparison, we all have heard of LASIK eye surgery. So we have this, and that's really to remove people's glasses. And you can see I have no trouble wearing glasses because it makes me look smart. But you can see we have an operation for a disease called otosclerosis, where we have a pretty good chance of improving your hearing from that. However, we have a 1% chance of having a dead ear, of going deaf. However, everybody signs up for that operation. Isn't that crazy? Would you have an eye surgery done, LASIK eye surgery, if I told you that a 1% chance of blindness? Probably not. So that just tells you how strong the stigma is with hearing loss. So stigma with hearing loss is generational as well, and it's really interesting, particularly around the Bay Area where everyone's tech savvy. Everyone wants the latest and greatest things, and everyone seems to be now wearing things in and around their ear, things that don't necessarily look like hearing aids, but look like hearing devices, so Bluetooth, iPods, all those sort of things that sort of dangle in and around your ear. When I was going through school, headphones were getting smaller, but now they seem to be getting bigger, and everyone wants, I guess it's kind of a statement how big your headphones are. Wouldn't that be nice if hearing aids could be the same? Maybe some of you think of hearing aids as that picture on the left. That's not really what hearing aids are anymore, right? They're not these big, hunky things. In fact, they're not even really these things in the middle anymore. They're really getting to quite discreet. And what I like about this picture is that it's most people don't have very short hair on the sides or are going balding, but at least the hearing aids, the stock standard hearing aids that we provide now are very discreet. And of course, there's a whole range of very new hearing aid devices, everything from very super powerful ones on the right there. So ones that you can't even see, that you might as well have just taken a picture of an ear and put it up there. They're completely hidden inside the canal. For those of you who like to do a little bit of background reading, this is an article recently published by myself and Dr. Vazbuch in our department. They talked about the evolution in hearing augmentation in terms of innovation. So just if we're sticking around hearing aids at the moment, there's a huge amount of innovation, both to reduce the stigma, to make them smaller, to make them connected with our world, with our phone, with our devices around our house, to make them more interactive and usable. There's some really neat hearing aids there that you can see, the one in the middle where it's completely hidden inside your canal. You just need to have someone change it every few months. And isn't it great that you can get a lot of these devices online or on Amazon and they're really accessible nowadays. We have lots of different devices that communicate with Bluetooth and wireless that can make up for, doesn't bring you back to how you were born, but improve situations where you have a dead ear on one side and a hearing ear on the other, and they allow you to communicate sound from one to the other. One thing that you'll see is really excellent around this area is the fact that wearables and hearing aids are combined into what we call earables, and it's the combination of wearing something in your ear that provides sound, that monitors your heart rate, that maybe tells you what you should or shouldn't eat, and those sort of things. But really importantly, this is a really big thing around legislation in the US, and these things that I have on, I don't think these are $196, maybe these are about $100. But isn't that crazy? The kind of the equivalent thing that you could buy today is kind of in the thousands of dollars. And if you do some really gross calculations of what Medicare and Social Security is paying for, it doesn't quite make it economical to get hearing aids today. And if you were to look at, where in society is there a similar markup between technology and what they actually charge you? It's probably movie theater popcorn, or maybe the butter that goes on top. It's really a huge markup in the technology that's within hearing aids. So really, hearing aids as an introduction to what is innovations in hearing loss is ripe for disruption. A few years ago, the US Senate passed this piece of legislation, which is is already changing our field. So they made a distinction between hearing aids and personal sound amplification devices. And so these things called PSAPs are now available over the counter or becoming available over the counter. These things, there's a whole variety of them. That's why there's a whole bunch of cut and paste things on the slide there that you today can access through Amazon or other online platforms. But they really are doing the job for most people who have run-of-the-mill, boring hearing loss that just need some amplification. Of course, you can get very fancy. You can coordinate them with your smartphone. You can even now get those that translate languages. I don't know if there's an Australian to American translator yet. But those that do health monitoring, computing for you. And I think this is just an amazing thing that's been done in this country to make the accessibility of the new innovations in devices to those with hearing loss. Often I get asked, what do you recommend? It's really the opposite. I almost recommend anything because almost anything is better than nothing. And unless you have a really complex type of hearing loss, most of these PSAPs will be good for you. So a lot of the people still don't want the stigma. They say, well, can you hide it? I just don't want anyone to see it. Well, yes, there are hearing aids available. There's the one there that up on the top, where you can completely hide it in the canal. No one can see. There's another. There's a bioengineer and a physician, Rod Perkins at Stanford, who are behind EarLens, who's a local company here. So we're very proud to say it's partly a Stanford invention. And what you can see here is one of the problems with hearing aids is that, and those of you that are tuning them up, but they start to squeak and squeal and you get sort of acoustic feedback. Well, this is a light-driven hearing aid where this little lens sits on top of your eardrum, and so it's powered by light, so you don't get the acoustic feedback problems. It means you can turn it up louder, and you can actually get really good frequency specificity above the range of normal acoustic-driven hearing aids. And this is a really basic one. So those of you that just have a little bit of hearing loss, mild hearing loss, you can get a sticker. You can stick it on the back of your ear and turn it up. It'll give you about 15 or 20 decibels worth of gain, and it's okay. Isn't that nice? No surgery, very cheap. You don't like it, take the sticker off. If you need a little bit more power, and these are for those, especially for those that can't wear hearing aids or have maybe a single-sided deafness and they need the other ear to hear some of the sounds. And we have a lot of different bone-anchored hearing aids. And this is what we used to do, or we still do a little bit, is the picture on the left. And you can see It's a little bit ugly, but it's very functional. It's a post that fits into the skull and transmits sound either to the inner ear on that side or crosses it over to the other side. And this is probably what we're doing now. There's a lot of different solutions where you can hide the post under the skin or have active implants hidden into the bone where, again, you can't really see what is there, and they just sort of clip on with a magnet. You take it off and you can't see it. There's a lot of other more active things. So for those of you, and this is kind of a narrow range of those that need a bit of a conductive boost, we can actually put things into your ear, hook them onto those ear bones and give them a stronger shake than they need to. So these devices are excellent. This is a really famous quote that I always like to bring up as well. So this is Alessandro Volta, an Italian physicist. So he thought it would be a really good idea to get, I think it was like 2 12-volt batteries, connect them up and stick them into his ear and report what they sounded like. I don't know even though my name might sound a little bit Italian, I don't know any Italian, so I couldn't translate this to you directly in Italian, but I guess it would sound funny. But if you translate that into English, he said the sound actually produced a boom within the head, followed by a sound similar to boiling a thick soup. I hope the thick soup wasn't his brain boiling in there, but what that actually did, that real insight into electricity or hearing electricity, actually led to the discovery and the implementation of the cochlear implant. And there was a lot of people behind the cochlear implant, including a number of Americans, but I like to put up the Australian there, Professor Graham Clark, who was very instrumental in this process. And of course, this is for those people that have traditionally severe to profound hearing loss, where you can't wear a hearing aid because it doesn't amplify enough. So we can put an implant into your inner ear. We can transmit that acoustic energy, put a small electrode array into your inner ear, and stimulate those spiral ganglion cells, the nerve cell bodies that collect the sound, and transmit that into the auditory cortex, and that's perceived as sounds. We were able to take people that get 0% sort of speech scores and actually make them able to hold conversations, which is a really amazing transformation. But that technology is a little old. What we've been able to do in the meantime is actually really push the boundaries of what we're doing with these cochlear implants. So you might have heard at the beginning, what we're traditionally doing for these are implanting that red area there, the severe to profound hearing loss. We're getting more and more aggressive, both with newer and brighter electrodes, with new pharmacological and soft surgery techniques. We're able to preserve low frequency hearing and give the implant into the higher frequencies. So low frequency hearing, for those of you particularly into music, is really important because it provides the warmth and a lot of the overtones of sounds, which you miss when you have a cochlear implant. So what we're able to do now is to sort of combine a hearing aid for the low frequencies into the electrical stimulation of the high frequencies. We call this a hybrid implant. But we still need to do better because only 5 to 10% of adult cochlear implants in the US actually receive them. And it's probably about a 10-year delay from when they fall into traditional criteria to when we actually do it. And that's for me, that's shocking because there's 10 years of missed time where people have changed. Of course, there's a lot of really cool things that happen here at Stanford. And just to talk to you about a few things in my own lab. And also to highlight an amazing, massive effort amongst our whole department. Too many investigators to list here about this initiative here that you can all go online and find out about. It's called the Stanford Initiative to Cure Hearing Loss, where our chair said we are going to do our best to cure hearing loss, which is a really big, audacious statement, right? But it's a really important goal because there's people in the department that are trying to do this, including myself. We're trying to bite off little bits and see if we can do that. So and Nora's introduction mentioned one thing that will be in clinical trial at the beginning of next year. For those of you that have holes in the eardrum, at Stanford, we invented a gel that you can squirt onto the eardrum and repair it instead of having surgery. For those of you that, and this is probably most of our children, are having ear tubes or had ear tubes at some point in their life, we're working on a drug therapy to kind of replace that. One of the big things, and one of the things I didn't say in my introduction, is in Australia you have a dichotomy. You have a lot of the coastal cities, you have a lot of the first world problems that we all have in the Bay Area. But we also have, in the north of the country, a third world area where you have a lot of indigenous communities with really terrible chronic middle ear disease and just these stinky discharging ears. So we're working on a lot of new antibacterials to fight these infections in the middle ear. Also in the introduction, it mentioned I was part of SPARC, which is the translational arm in therapeutics at Stanford. And currently, our drug discovery course is working on new treatments for Meniere's, otosclerosis, noise-induced hearing losses, and a number of other conditions. So we are trying. But remember, there's this big initiative at Stanford to try and cure hearing loss. So, the cochlear implants are good, but people really want to try and restore their natural hearing. And it's really sad because the ear is one of those organs in the body that doesn't repair itself. Once it dies, it's kind of like, well sorry, that's it. Unlike the rest of the body. Unless you're a 6-day-old rodent, you lose that reparative ability. So for some reason, chickens and really young rodents, you can wipe out their entire hair cells and they regenerate magically and they can connect to the right things and all that sort of stuff. Everything else, it's once you lose it, that's it. So it's really sad. But we have a number of really dedicated people working in the lab to look at both gene therapy, stem cell therapies in the ears, and trying to hit a lot of different molecular targets in the ear. Hopefully, I'll be able to give an update on this talk soon and talk to you more about those sort of innovations. And I know this sort of, when I give these sort of talks, it's very popular, so I wanted to leave a lot of room for questions toward the end. But if you could take away anything from here, it's to realize that hearing loss is actually not just important for hearing, but it actually goes to who you are as a person, whether or not you hear those people around you. And husbands and wives, those in your room, you can like nudge your partner and say, see, I told you so, if you need to. But it really is important, but it's also difficult. I have the same problem talking to my father who for probably 20 years needed hearing aids. And I'm saying, Dad, look, you put your son through medical school. What's the point if you're not going to listen to his advice? I think we should all be really excited about what we have today, the innovations that we have, both in devices, the emerging drugs, and what's coming on the horizon. So I'm hoping this video plays, but this is a video given to me by Dr. Gurgel, who I mentioned, and it doesn't really talk about hearing loss per se, but it talks to how hearing it impresses on you as a person. And this is music therapy in aged care facilities where they're suffering from dementia. But you can see the effect that restoring some sounds and some familiarity of music and the difference it can make on people. So we'll see. Maybe we'll miss that sound there, so we can try again. This is a really strong mic, so I'm sure I can pick it up. Oh.
The brain and any other stimulant.
Okay, let's start that again. There we go.
Music has more ability to activate more parts of the brain than any other stimulus.
By exciting or awakening those pathways, we have a gateway to stimulate and reach somebody who otherwise is unreachable.
Always brings a tear to my eye when I see that guy. He's such a sweet guy. But you can get the idea of how much of a difference sound makes, more than just the actual sound, the meaning of sound in terms of music. And so I wanted to finish there, and I'm happy to answer any questions. At the back.
You mentioned noise-induced hearing loss, which was being brought up on rock music. Might be a few of us have that. How close is anything for depleted hair cells?
That's a good question. So the question is, for those of us that are grown up on rock concerts and noise-induced hearing loss, how close is the treatments for that, including hair cell regeneration? So, it's It's a problem for every generation. In fact, it's becoming more of a problem now for those that are wearing hearing devices, and there's no controls in the sound that they wear. I'm sure it's going to be more of a problem for the younger generation than it is for the rest of us. So depends how bad your noise-induced hearing loss is. So almost all the things that I talked about today are available for noise-induced hearing loss, both devices. In terms of drugs, there's some clinical trials happening now looking at things that could potentially prevent it. Of course, it's always better to prevent it than to reverse it. But then what about the rest of us that have noise-induced hearing loss? And I have a little bit, and restoring that. So, it's still a little bit on the horizon, and we always say sort of 10 to 15 years here. So that's kind of what we're sort of saying. There's a lot of very promising candidates in preclinical and very early phase 1 trials. So not too far, hopefully.
Thank you.
Yep.
You talked, I think you said P-snaps?
PSAPs, yeah, personal sound amplification devices, yeah.
Are they in different grades? I mean, how does a person go to, and where do they go to buy a P-snap?
Yeah.
How do they say, or if they've had a hearing test, can they then ask the audiologist what my grade is and take that information and purchase a P-snap?
Yeah, so the question is about PSAPs, personal sound amplification devices, and where you can buy them. So it's becoming more and more common. So you can buy them online now. You can get onto any, I keep saying Amazon, not just to mention things, but there's not many other, there's a very big shopping platform. So you can get on there now and you can type in personal sound amplification device or hearing aid or something, and a whole bunch of things will come up. So you can get on there now. A lot of them are sort of off the shelf, kind of like the off-the-shelf glasses that you might get from a supermarket. But others can have some involvement in terms of fitting, where you can interact with the computer or an app on your phone that would help fit them. And soon with that legislation, you should be able to go into your pharmacy, just like you buy an over-the-counter thing for the cold and flu, and buy them from there. So today you can get them online.
But I mean, how do you pick the strength?
Most of them are pretty, the question is, how do you pick the strength of the PSAP? Most of them are very self-explanatory. You can just dial them up or dial them down. And most of us, that's pretty good. Of course, if you have very complex fittings, you might need an audiologist's help, but the run-of-the-mill things are okay. Yeah.
What's the new research on auditory processing deficits?
So the question is about research around auditory processing deficit. So for those of you that are unfamiliar with that, as a very basic way of understanding what auditory processing disorder is, it's when most of these things are still there, the pathways to hearing, the eardrum, the inner ear, and the nerve. However, it's kind of like having a good telephone, but the wires may be terrible, or the receiver of the wire is terrible, so something in the brain. Interestingly, there's a lot of evidence to show that cochlear implants benefit in auditory processing disorder. Doesn't obviously suit everyone, but the theory behind that is that if you can kind of rejumble the code that's going through the auditory nerve and change that into a more simple electrical signal, it can help. So there's definitely that. In terms of therapeutics, I don't think there's anything at the moment that is aimed at that, but definitely as a device that is. But there's a lot of cognitive, behavioral things that can help with auditory processing disorder. Yeah.
What about the fact you look in the paper and it says for $200, we can take care of your hearing loss and so on, which to me, I think, come on, what's the deal with that?
Yeah, the question is how legitimate is $200 hearing solutions? Well, if I deconstructed the hearing aid that you buy for $5,000, it's probably worth $30, so $200 is still a markup. So I think it depends, but as a blanket rule, it probably is okay for most people. So I don't think you should shy away from price. Of course, if you have complex hearing problems, if you're needing connectivity, if you're needing extra features and things like that, the price starts to add up. would think that the average price of hearing aids in the very near future, I'm talking about in the next year or so, would come down in the thousands to hundreds. So I think there's going to be a big change in price. Of course, there's a big 5 or 6 big hearing aid companies that are going to fight that, and they're going to tell you that it's not good enough, but it really is good enough for the run-of-the-mill person. Yeah, question there.
If you have the kind of hearing loss where higher frequencies are a problem but lower frequencies aren't, would a standard hearing aid work for that?
Yeah, so the question is about hearing loss, and it actually probably the most common hearing loss associated with aging is what we call the ski slope hearing loss. We have normal or maybe slight hearing loss in the low frequencies, and you run off a ski slope to severe to profound in the high frequencies. And just to take everyone back, that's actually really important because most of the speech frequencies tend to be in those frequencies that we, or at least a lot of the sounds attached to consonants, so T's and P's and things like that. So with low frequency hearing, you can hear someone talking, but you actually no idea what they're saying. You're losing the content, and that's the most common complaint. So the question is about run-of-the-mill hearing aids. Yes, because that's probably the most common hearing loss that we see. There is a lot of different solutions for that. When we talk about run-of-the-mill hearing aids, the easiest one for that sort of hearing loss are what we call an open fit hearing aid. Because if you're occluding the canal, if you're trying to hide things in the canal, you tend to boost the lower frequencies kind of unnaturally. So having something that ventilates and opens tends to counteract that. So obviously it depends if you're not too severe, there is a lot of, most hearing aids will actually suit that. Of course, if you're down in the very low regions, that's where we're talking about the thing that I mentioned with cochlear implantation, where we're trying to save the low frequency hearing by putting it in using special techniques and just implanting the high frequency. So yes.
Thank you.
At the back.
If I'm suspecting hearing loss, is the first step to go see a doctor or to have a hearing test?
Absolutely. So the question is, if you suspect hearing loss, what's the first step? To see a doctor or get a hearing test? Get a hearing test. Because sometimes it might be something else. Sometimes it might be more severe than you have. You can get a hearing test very easily there's lots of audiological places around, but you can actually get online and do very gross hearing tests. You can get apps on your phone that can do very basic hearing tests and things like that, so you can search for hearing test in the App Store and things like that.
A second part to the question, how do you convince someone who does not believe that this is necessary? You hear everything.
Yes, so the question is, how do you convince someone who doesn't believe that they have hearing loss? And I see everyone nodding in here. I think that's part of it. If I knew the real answer, the perfect answer, maybe it would save a lot of the other work that we need to do. That goes into a lot of psychology around convincing people things. So I think it's very hard. And one thing that I often say as a sort of a side joke in my clinic is we don't offer marriage counselling either, because there's years and years of communication issues that happen between people, and it's like, well, we're not here to be the judge or the executioner in people's marriages, but it's really tough. It really is difficult. And a lot of my own personal experience from my family and personal experience from the patients, it's very hard to tell people that they have a problem when they don't kind of recognize it themselves. But it's kind of they may not recognize that they have hearing loss, but they start to nod when you say, well, tell me about your social life. What are you doing now? Do you go out to restaurants? Okay. What about family gatherings? When there's children or other relatives running around, do you enjoy those? And okay, well, you start to go through all the different situations where hearing loss is a problem, and that it starts to have more meaning to them than the fact that they're hearing loss, and that starts to outweigh the fact they might have hearing loss. So that's the biggest thing, is to start to talk to them about situations where they may be struggling, that have meaning to them in their life, and then gradually, hopefully it adds up to they say, well, you know what, I can just get a hearing test and see. Funnily, had a situation with my own grandparents where everyone was certain my grandfather was having trouble with his hearing, and my grandmother was bugging him, going, go get your hearing tested, get your hearing tested. And so he said, okay, I'll do it if you do it. Turns out my grandmother had the one with the worst hearing loss.
maybe it'll happen in the future, but right now, there's nothing that can be done if you've lost, the amount of hearing that you've lost can't be recuperated at all in this day and age, right?
Yeah, so the question is, can you recuperate everything if you've lost everything? Yeah, so you can't recuperate natural sound through, I guess what we're working on in terms of stem cells and hair cells in the inner ear. You can go from, if you look at what the outcomes of that are in terms of understanding speech, you can go from 0 scores to 80% scores using cochlear implants. So we can recuperate lots. Of course, people are delighted when they have cochlear implants, and that's kind of the things. If you go on YouTube and you look at activation videos of cochlear implants, that's where you see like tears rolling down people's eyes because of the difference it makes. So you can recuperate a lot and make a big difference in people's lives. Definitely isn't natural, but it definitely impacts.
With the cochlear implant.
Correct. Yep. Question there?
Yeah, in the beginning of your talk, you mentioned association between dementia and hearing loss. Is that correlation or cause and effect?
Yeah, the question, and it's a very good scientific question about the association between hearing loss and dementia and causation versus correlation. With the more, everything's leading more and more to say causation. It's if we exclude a lot of the other things around. And most of that work, there's a few papers that I just highlighted up on there, has been looked at basically cognitive load and stimulation through hearing. So probably causation as an independent risk factor, but don't know as a scientist. Oh yeah, just down here.
What did you say?
The whole talk?
People with ADD, auditory processing, and hearing problems, when an obvious aid to that is turning up the volume. But I've come to learn that turning up the volume actually also lowers the ability to hear. I don't know what you call it, but I might call it noise saturation. Is there any way of balancing that?
Yeah, so that question is around...
can hearing aids affect that in some
yeah.
ways, or can they be adjusted for that?
Yeah, so the question is around what we call auditory processing disorder, both in children and adults. But we not only have hearing loss in terms of hearing that goes down, but also the processing of hearing. So we have lots of people that come in. It's very common where you do an audiogram and it's okay, but they're sort of struggling in these situations. And the question is related to can things make a difference in that? Yes. So typically with auditory processing disorder, you can overwhelm the auditory cortex by turning it up louder and louder, and it's kind of the...
I'm not saying just with auditory processing.
But all the other associated, yep.
Just plain hearing loss and also with ADD.
Yes. So I guess the original question is those people that have trouble, when you turn up the volume, it kind of actually makes the condition worse. And we can measure that, and it actually is a true effect. So there are some people with those issues. So yes, there are assistive things that you can do with hearing aids that can do that. You can boost things up, and we can test your word recognition, and then if you turn it up a little bit more, it starts to go down. We can sort of get the balance right. It is a very difficult situation and a common situation, but in terms of therapies, not much out there, but in terms of ways that you can interact with listening devices, hearing aids, get them connected into your environment, definitely ways to make that better. And there's a whole pamphlet that we hand out in clinic to help that situation. Yeah.
I noticed that my audiologist suggested that I just might be surrounding myself with too much sound, and so I turned everything way down, and within a few days I found that I needed the TV at literally less than half the volume what I've been listening to a lot of the time.
And that's, yes.
But there's still that inclination to increase it a little bit, Is there any way of overcoming that?
Yeah, so the question, I'm just repeating it for the video. The question is around your personal experience where you did notice that you were turning it up and were struggling, and your audiologist suggested that maybe you should turn it down, and it actually probably made it better for you. And that is actually a common complaint as well. So there are definite technologies inbuilt with hearing aids to help do that. There's ways that hearing aids, I didn't get into it, that can deal with noise filtering in different situations that can help. They're very sort of advanced with direction of their microphones that can help with understanding who the speaker is and things like that. And a very simplified answer to that, yes, there's lots of things, but it gets very detailed, and that's where most hearing loss is okay for personal sound amplification devices or over-the-counter hearing aids, but where you're having complex issues with processing, it's better to involve an audiologist. Question here?
Yeah, I want to know if having the mumps at the older age as an adult can affect the hearing.
Yeah, the question is around whether or not having mumps as an adult affects hearing. Not that I know of. It definitely affects your hearing if you're a child, or especially in utero, where there's a big association between the mumps virus and hearing loss. I don't know if any research behind in it as an adult. Yeah, question.
Is hearing loss always progressive, or does it sometimes remain at the same level?
So the question is hearing loss always progressive, or does it remain at the same level? It depends. So age-associated hearing loss, which is most commonly, it tends to be progressive. But then you have those people that, they're presenting in their late 30s with age-associated hearing loss, and those that have really robust hearing into the 80s and 90s and seem to have normal hearing. People that have fast decline, slow decline, seem to be stable. There's people that have then it has an event where they have a sudden drop and then they may remain stable for a while, or there's those that are just fine. So that's a really long way to say it depends. Okay, question there? Oh yeah, sorry. Next.
You know what? Everything seems so loud to me. The fans or anything. Can you explain why that sound is so loud? I can't. You want to run away from it.
So the question is around, I think you're getting into the comment about fans or other background noise sounding loud. And I guess there could be two ways to look at that. One is a condition called hyperacusis. And there's often hyperacusis symptoms associated with hearing loss. And to explain it non-scientifically, when you have a region of your hearing that's kind of missing out, it's kind of like the other areas strain a little bit louder to hear. That's why we get tinnitus or hyperacusis and things like that. So yes, funnily enough, we can balance that out. So if you have hearing loss, but you're also having struggling to have, well, I guess some sounds are too loud, replacing those lost sounds can sometimes make the other sounds seem more balanced. So that's kind of the run-of-the-mill answer to that question. Yes, you can explain it from having hearing loss in other parts of your inner ear. Sorry, question here.
I understood that if you get a hearing aid, your brain somehow adjusts or changes a little bit to adapt to it. So what does that do to your normal hearing? Is that essentially bad for you in a way?
So yeah, there's sort of two questions in there. One is, does your brain adapt to having hearing aids? And the second one is, is hearing aids bad for your normal hearing? There's probably some adaptation that happens from having hearing aids. Definitely there's a lot of adaptation that happens when we implant ears that have been without sound for so long. And we rely on that adaptation because you're going to need to understand this new weird sort of electrical sound with new frequencies. The second thing is amplifying your hearing bad for the remaining hearing? And interestingly enough, not really. I guess if you're cranking it up to unsafe levels in those regions, but your hearing aid is kind of like an equalizer. You can turn it down for the areas that you don't need to amplify and turn it up. It's not going to hurt the areas that you're already turning it up for. So that's a common question, but you shouldn't resist getting hearing amplification to protect the rest of your hearing. It's actually the opposite. You want to try and preserve as much of the other hearing and the cortical function associated with that as possible. Yes, question?
Are there hearing aids that you were talking about, kind of like the frequency? You could change the frequency. I mean, the stuff that you don't want to really hear or too loud or whatever, like she was saying. Can you change the frequency so you're not really hearing things that you...
Yeah, so the question is around, is there hearing aids that you can change the frequency for that you can adjust? So that's part of what an audiologist does, that you go and you have your frequency things. You can definitely shift frequencies in hearing aid program. You can make things, especially if you are in an area where you can't hear, you can shift some of that speech frequency into an area that you can hear. Obviously the voice sounds a little bit natural, but you can do that. So there's techniques that you can do in that. There's often a lot of sort of intelligent programming in hearing aids where you go into different situations and you kind of can click, oh, I'm going into a restaurant, or I'm going into the home and things like that. And they are sort of adaptive around that. So yes, both physically and programming, and there's some that are sort of limited for the patient to be able to do as well. A question at the back?
Are cochlear implants covered by insurance?
The question is are cochlear implants covered by insurance? We rarely have problems with insurance and cochlear implants. They generally are. In fact, the sad thing is that I have a lot of patients where they're sort of struggling with hearing aids, but they can't afford the hearing aids, and they're sort of just waiting. I'll just wait till my insurance covers my cochlear implant, and so they decline a little bit further. So as a general rule, of course, we don't speak for every insurance company. Insurance is okay with cochlear implants. At the back.
What is the future of hearing loss research and development of the issues that we're facing today without basically device?
So the question is, what is the future around in-ear therapies, I think you mean. So not talking about device. So if you exclude a lot of the external ear, middle ear therapies, which I presented up there, the future is a lot. So I skipped over them a little bit, but there's, for those of you that are interested, you can go to the Stanford Initiative to Cure Hearing Loss, and they kind of break up into a few sections. One is there's a big field of gene therapies. So you can deliver a virus that can carry some regenerative messages to the inner ear and get them to regenerate that way. Some of them are biological approaches to try and get the cells that are in the ear to sort of the supporting cells to divide and create new hair cells. And they're the kind of the two main areas. There's it's sort of in the, I wouldn't say in the infancy, but I guess in the toddler or young child stage, where there's a lot of things in really promising in preclinical trials and very early sort of phase 1 trials now. So we'll know the results very soon about whether or not we can start promoting them. So there's a lot of things and a lot of avenues that people are trying to do that in the non-device area. But I guess part of the talk was to show that the devices aren't that bad. Everyone asks that and goes, "Oh, come on, my clock's ticking. I need this to work now." I don't know. Yeah, well, it's not tomorrow, else we would have had a press release. We often say with pharmaceuticals, the development timeline is kind of 10 to 15 years. And I think we're kind of in the early stages of that, so maybe 10 to 15 years away. Yeah. Over there.
My hearing loss is a little bit different in that I have autosclerosis, had a staphylectomy. Should I need it on the other side and it doesn't go accordingly, would a cochlear implant fix the hearing loss?
Yeah, so the question is around your unique situation with otosclerosis, where you had that operation with the 1% risk of deafness, and hopefully it worked. But the question is, what happens if I have the surgery on the other side and lose my hearing? We do cochlear implants in that situation often. And so, yes, because with otosclerosis, if it doesn't work, usually the thought is that you kind of lose the cochlear function, but you still have an okay nerve there, so you can still stimulate that with electricity. Interestingly, there's an ongoing Spark project now to look at a drug therapy for otosclerosis, but obviously, using the analogy, the pipeline is still a little bit far away.
What is otosclerosis?
So otosclerosis is a really interesting disease. So it's an issue of bone remodeling. And it's not many diseases that you find that only occur in humans and only occur in a specific part of the ear. Is that my time to... I don't know what that was. Maybe it was my computer doing something silly. Hold on, let me turn it off. The question was about otosclerosis. So, so it occurs just in humans, just in the inner ear. And it's kind of like every time that you get an injury to your bone, it'll remodel and turn over. So your bone's always constantly ongoing remodeling. So in otosclerosis, there's a disorder of remodeling. Instead of being just right, like Goldilocks, it's too stiff in some areas. And normally you rely on that picture that I put on before, that bone acting like a piston inside your cochlear, and it should act up really, really smooth. But what can happen is that piston can get really fixed due to that bone remodeling problem. It kind of stiffens up. And so if it's sort of stiff, it's not conducting sound in that same fashion. It can actually become completely fixed. So it's a fixation of that third bone, that stapes bone, in the inner ear that doesn't work.
And what kind of symptoms will give to the person?
Yeah, so generally it's hearing loss, and it's generally hearing loss without any other cause. So it's usually a kind of a classic conductive hearing loss when people haven't had ear infections. Usually you're presenting earlier on, so in the 20s and 30s. It's very classic for there to be a hormonal association. So women, when they get pregnant, get a sudden hearing loss or a very rapidly progressive hearing loss. Otosclerosis is often the cause there.
Thank you.
Yes.
Can you give us an update on implants, for example, like the Lyric? It was for making it waterproof, because some people can't use them because they're swimmers, for example. And they were, my understanding was they were trying to perfect one that swimmers could use. I just wondered, do you know the status of that?
Yeah, the question is around the status of the Lyric hearing aid in particular and whether or not it's waterproof. Actually, I don't know how they're going with making that waterproof. Of course, it sits in the canal, and if you get water in the canal, it's a big problem. And that's, I guess, a challenge with the Lyric hearing aid is the fact that you have to change it every now and again. There are other hearing aids that can be in that situation in terms of waterproof. If it's there's I guess I've presented maybe 30 or 40. There's kind of a whole bucket of more different styles of hearing aids. There's implantable hearing devices that you can actually implant them beyond the skin. Those bone anchored hearing aids, if it's right for your situation. But in the Lyric, I don't know specifically. Yeah.
Sudden hearing, a temporary sudden hearing loss. And I experienced that this last summer. So I had already had some hearing loss from just aging. And then I woke up one morning and one ear was virtually dead. I tested at 24% with such severe distortion that a hearing aid wouldn't help. But 2 weeks of prednisone did help. What kind of thing causes that?
So the question is around, we call it sudden sensorineural hearing loss. And I think the really thing that made me happy at the beginning, we said it was temporary. So the majority of people, it's not temporary, it's permanent. So there is that condition, and it's a whole group, it's kind of a family. And often we label it idiopathic, which means we don't know. So it's people wake up suddenly and they just lose their hearing in one ear, and that's devastating. There's a whole bucket list of things. There's vascular causes, there's autoimmune causes, inflammatory conditions that are associated with the inner ear. There's sort of endocrine conditions that do that. Remember the inner ear has this really tiny blood supply, so if you interact with that at all with inflammation or blocking it up with an embolus or something like that, it's really sensitive to losing, and because the inner ear doesn't repair itself, it doesn't come back. So there's those things that we're lucky enough to find and reverse, and we put a shotgun approach of putting steroids onto it and they come back. But majority of people we never find out or can cure. Yeah. Yeah. A question?
This is actually a guidance question that you may or may not want to answer, but some of us don't have hearing aids, but we'd like to explore them. And it appears that audiologists are very wedded to one brand or another, usually very high end. And if you are just now starting that journey, what would you do to kind of see what's out there and what would actually work for you, given all the choices that there are?
Yeah, so the question is, I actually have no problem answering that question. The question is around, I guess it goes back to incentives for audiologists. Are they incentivized to, I guess, sell you a hearing aid? Are they incentivized to avoid particular brands? They have sort of side deals going on where they're incentivized. And faced with all that, where do you start and how do you get that? So I have no problem recommending anyone to Stanford Audiology because they don't get paid a commission. They get paid for patients they see. So I think academic centres are generally good. Outside of academic centres, I don't know. So there are plenty of really good audiologists outside of academic centres. There's also ones that you hear bad stories about. I think generally as a profession, they do okay. But certainly in academics, it's because they're there to treat the patient, it works. So I think if you're worried about all of that, come to Stanford or another academic centre where you can get seen and you kind of sort of know. I'm sort of the same. I talk a lot of people out of surgery, or I talk a lot of people out of needing something because I'm like, well, if I was in your situation, would I want that? So you have that sort of approach in academic medicine. So that's one start. You can sort of go to, I guess, a trusted area. Hopefully there's lots of people around you and they can say, oh, I actually had a good experience with this or not. And when you go there, the really good thing, and we have a law in California, I think it's about a 40-day kind of money-back guarantee, where you can buy hearing aids, and by law, the people, if you don't like them, you can just hand them back and get your money back within, I think, about 40 days, so around that. So you can sort of almost try before you buy, but you have to pay and then you can get your money back. But there's a way of doing that. The other way is that if you have a very basic things, you can do it on yourself by those online mechanisms that I mentioned as well. So and those things can be in the orders of hundreds of dollars, so very accessible. The problem with that is that there's so many of them, I can't recommend a particular one. Question there?
Just as exercise and nutrition is good for general health, are there habits for good oral health that will prevent the rapid decline of hearing?
Yeah, so about exercise and nutrition for your health. Is there the kind of the same thing with hearing?
Good habits.
Yeah, so I'm going to sound really boring about that and say yes, and it's the things that you expect. So we actually have done some published in this area. We looked at association of cardiovascular risk factors in hearing, and yes, there's I don't know if it's correlation or causation, but there is lots of links between general cardiovascular health and hearing health. So the things that we already know about eating well, exercise, salts, blood pressure control, those sort of things, all work for your ear as well. So very boring, but yes, there's plenty of things that we can do, and unfortunately, they're things that we need to do to improve our overall health as well. One more question?
I have the impression that tinnitus or tinnitus, however you prefer, is pretty common. And I'm wondering if it's ever benign, or if it's sometimes, or is it always an indication of something brewing?
So the question is around tinnitus or tinnitus, potatoes. Tomatoes, more relevant to me. And whether or not it's always something relevant, or whether it's benign or indicates something. So I think almost everyone in the audience, including myself, has some sort of tinnitus. So hopefully it's not bad. No, really, it's tinnitus is usually a reflection of hearing loss. So there are a small group of patients that have tinnitus without hearing loss, but you can almost guarantee someone with hearing loss will have tinnitus. They kind of go hand in hand. And the American Academy of ENT recommends as first-line treatment for tinnitus is actually hearing amplification in those that have hearing loss. And so I see a lot of patients that have okay, or sort of they're saying, look, I'm hearing, it's fine. You ask them all the questions and the situations that they're having. They seem to be fine from their hearing loss, but their tinnitus is really bugging them. And so for those patients, we're actually prescribing a lot of hearing aids as tinnitus therapy rather than hearing for their hearing. There's a lot of other well-known tinnitus therapies. So, of course, there are situations where tinnitus can be bad. Of course, if it's severe and very loud in one ear compared to the other, we usually need to investigate that. Usually it's nothing, but we usually end up investigating that. But it's kind of is hearing loss or is tinnitus always representative of something bad? Well, is hearing loss? Well, it depends. There's a whole category of things. And I know that people I always good thing to end on because interesting. I usually get a tinnitus question, so lucky it's last. Is when I talk to patients about tinnitus, it's really a common thing, and it's something that worries them. So it's really important. And people always say, well, is there a cure for tinnitus? And I say, if there's a cure for tinnitus, then I tell you, I'm not hiding anything from you. There's nothing that will take it away completely, However, most people's tinnitus, if you ask them to rank, it's kind of like a 7, 8, and a 9. It's really bothersome. But there's lots of things that we can do to take that down, so that you still have tinnitus, but it's not bothering you, or you're not aware of it, or it's not, you don't rank it as high. And that includes both hearing amplification, cognitive behavioral therapy, sound devices, masking, sometimes pharmaceutical therapies or other devices. So there's lots of things that you can do to bring down tinnitus. Maybe not to 0, but a lot of people that I see with 7 or 8 out of 10 tinnitus, they're like, oh, I wouldn't mind if it was a 3 or a 4. And so there's lots of things that we can do there. So there's a whole bunch of I guess a lot of us in the department that deal with hearing loss. We're all happy to see anybody. We have the Stanford otolaryngology website. We keep everyone updated with our clinical advances and our research. So I'm happy to answer any other questions in the future, but thank you for coming out tonight.